Hello everybody. Today we are going to discuss about non-ST elevation MI. So the spectrum of acute coronary syndrome ranges from the unstable angina to non-ST segment elevation myocardial infarction to ST segment elevation myocardial infarction. The latter condition is usually caused by the acute total obstruction of coronary artery, and urgent reperfusion is the mainstay of treatment. In contrast, the non-ST segment elevation acute coronary syndrome, unstable angina and Nstemi are usually associated with the severe non-occlusive lesion in culprit coronary artery. So by definition, the ACS traditionally presents with the specific clinical feature that can help distinguish it from stable angina occurring at rest or within the minimal exertion, usually lasting more than 20 minutes, being severe or of a new onset, or occurring within the crescendo pattern, that is more severe, prolonged, or frequent. In the absence of ST segment elevation on ECG, these patients are characterized as having Nstemi ACS. Among patients with the Nstemi ACS, those with the evidence of myocardial necrosis on the basis of serum biomarker have diagnosis of Nstemi, whereas those without evidence of myocardial necrosis are diagnosed as with unstable angina. With increasingly sensitive biomarker for myocardial necrosis, the proportion of Nstemi ACS patient meeting the criteria for Nstemi has increased, where that of the unstable angina has decreased. Regarding pathophysiology, the development of Nstemi ACS is caused by either reduction in the supply of blood flow and oxygenation and increase in myocardial oxygen demand, or both. The six broader etiologies are plaque rupture or erosion with superimposed non-occlusive thrombus, dynamic obstruction, that is coronary spasm, coronary artery dissection, progressive mechanical obstruction, inflammation and arthritis, and condition leading to increased myocardial oxygen demand such as anemia, sepsis, and hypoxemia. Individual patient may have several of these processes contribute to the onset of their Nstemi. So plaque rupture and erosion. Atherosclerosis is the silent process that usually begins 20 to 30 years prior to the patient's clinical presentation. So plaque rupture and erosion can be precipitated by the multiple factors like endothelial dysfunction, plaque lipid content, local inflammation, coronary artery tone at the site of irregular plaque, and the local shear stress forces, platelet function, and the status of coagulation system. This process culminates in the formation of platelet-rich thrombi at the site of plaque rupture and erosion, and it results into the acute coronary syndrome. So thrombosis, coronary artery thrombosis plays a central role during pathogenesis of Nstemi ACS. So the antiplatelet therapy has been directed at decreasing the formation of thromboxane A2, like aspirin, means which is done by aspirin, inhibiting adenosine diphosphate pathway of the platelet activation, which is done by the clopidogrel, prasugrel, ticagrelor, and directly inhibiting the platelet aggregation. And secondary homeostasis simultaneously with the formation of the platelet plug, plasma coagulation system is activated. Following plaque rupture and ulceration, the injured endothelial cell on the vessel wall become activated and release the protein disulfide isomerase, which act to cause conformational change in the circulating tissue factor. Tissue factor can then bind to factor 7A and form the protein complex, leading to the activation of the factor 10. With activation of the factor 10, thrombin is generated and act to cleave fibrinogen to form fibrin. Thrombin plays a central role during arterial thrombosis. It converts fibrinogen to fibrin in final common pathway for clot formation. It is the powerful stimulus for platelet aggregation, and it activates the factor 13, which leads to the cross-linking and stabilization of fibrin clot. So this is the diagram of the major component of the clotting cascade and the areas targeted by the antithrombotic agent. Like, so we can see here this tissue factor in the 7A causes the activation of the factor 10A, and then prothrombin is converting into the thrombin, which results into the thrombus formation. And on the drugs like fondaparinux, low molecular weight heparin, and fractionated weight heparin, they are acting on the factor 10A, and the drugs like um, Aspirin, clopidogrel, they are acting, and this glycoprotein 2B3A inhibitor, they are acting on the platelet and prevent their aggregation. So, next pathophysiological event is the coronary vasoconstriction. Another etiological factor for the Nstemi is dynamic obstruction, that is coronary vasoconstriction, and the process is identified in three settings: the vasospasm in the absence of obstructive plaque, vasoconstriction in the setting of atherosclerotic plaque, and the microcirculatory angina. So vasospasm can occur in patients without coronary atherosclerosis or among those with non-obstructive atheromatous plaque. So vasospastic angina appear to be caused by hypercontractility of vascular smooth muscle and endothelial dysfunction occurring in the region of the spasm. So Prinzmetal variant angina with intense focal spasm of the segment of the epicardial coronary artery is the prototypical example. Such a patient have the rest pain accompanied by the transient ST segment elevation. Vasoconstriction more commonly occur in the setting of significant coronary atherosclerotic plaque, especially those with superimposed thrombus. Vasoconstriction can occur as a result of local vasoconstrictor released from platelets such as serotonin and thromboxane A2. So vasoconstriction can also result from the dysfunctional coronary endothelium, which has reduced the production of nitric oxide and increased the release of endothelium. Adrenergic stimuli, cold immersion, cocaine, mental stress can cause coronary vasoconstriction among susceptible vessels. The third setting in which vasoconstriction is identified is microvascular angina. In this condition, ischemia results from the constriction of small intraluminal coronary resistive vessels. Although no epicardial coronary artery stenosis are present, coronary flow is usually slow and does not increase appropriately in response to variety of signals. So vasoconstriction should be considered in all cases of MI with no coronary artery stenosis, sometimes referred as MINOC. So next event is the coronary artery dissection. Coronary artery dissection is uncommon but important cause of acute coronary artery syndrome. Most cases are associated with atherosclerosis and can be seen during interventional coronary procedures such as complex percutaneous coronary intervention. However, spontaneous coronary artery dissection is increasingly recognized cause of dissection, accounting for 4% of all ACS. It is especially significant contributor to ACS in women. Now the next is progressive mechanical obstruction. Another etiology of Nstemi ACS results from progressive luminal narrowing. This is most commonly seen in the setting of restenosis following PCI. However, angiographic and atherectomy studies have demonstrated that many patients without previous PCI shows progressive luminal narrowing of the culprit vessel, likely related to rapid cellular proliferation in the period of preceding the onset of Nstemi ACS. Now, type 2 myocardial infarction. Type 2 myocardial infarction is defined as MI precipitated by the condition extrinsic to the coronary arteries, often among patients with the poor coronary stenosis and chronic stable angina. This change could occur either as a result of increased myocardial oxygen demand or decreased coronary blood flow. So, conditions that increase the myocardial demand include tachycardia, for example, supraventricular tachycardia, new onset atrial fibrillation with rapid ventricular response, fever, thyrotoxicosis, hyperadrenergic state, elevation of left ventricular afterload such as hypertension or aortic stenosis. Type 2 MI can also occur as a result of impaired oxygen delivery, as in anemia, hypoxemia, hyperviscosity states, and hypotension. With expanded use of type high sensitivity troponin, type 2 MI is increasingly recognized entity among hospitalized patients. Now regarding clinical presentation and diagnosis. Regarding history and physical examination. The description of ischemic pain is the hallmark of ACS. Ischemic chest pain is usually described as discomfort or pressure that may be brought by exertion or stress and relieved by rest. However, in STEMI ACS, the pain occurs at rest and is often not treated by nitroglycerin. It is generally located in the retrosternal region, but sometimes in the epigastrium and frequently radiates to anterior neck, left shoulder, and left arm. The physical examination may be unremarkable and may support the diagnosis of cardiac ischemia. Signs that suggest the ischemia and diaphoresis, pale, cool skin, sinus tachycardia, and fourth heart sound. Elevated jugular venous pressure, third heart sound, and rails on lung examination suggest the presence of heart failure complicating ACs. Now regarding ECG. ECG is the most widely used tool for evaluation of ischemic heart disease and should be performed within the minutes for patients presenting with suspected ACs. In Nstemi ACS, ST segment depression and T wave changes occur in up to 50% of patients. Normal ECG does not exclude ACS and should be repeated at regular interval among individuals with suspected ACs. Additionally, normal ECG or anterior ST segment depression may occur when left circumflex coronary artery is blocked. So, among patients with signs and symptoms of persistent myocardial ischemia, in whom standard 12-lead ECG is non-diagnostic, additional leads such as V7 to V9 to look for posterior MI can be helpful. Now, regarding cardiac biomarker, unstable angina is not associated with any detectable damage to myocyte. The diagnosis of Nstemi is made if there is biochemical evidence of acute myocardial injury, preferably cardiac troponin T and I, in appropriate clinical setting. This is defined as serial rise or fall in cardiac troponin with at least one value greater than 99 percentile of upper reference range, either symptom of acute myocardial ischemia, new ischemic ECG changes, development of pathological cleavage, imaging evidence of new wall motion abnormality, or loss of viable myocardium, or identification of coronary thrombus by angiography with intracoronary imaging and by biopsy. So type 2 MI is associated with elevated cardiac biomarker of necrosis and also include evidence of ischemia by symptom ECG and imaging. However, in type 2 MI, the oxygen supply and demand mismatch is not caused by coronary thrombosis. There are a number of causes of type 2 MI, including heart failure, arrhythmia, hypotension, hypoxemia, and anemia. The limitation of prior generation troponin assay is that they tend to have low sensitivity in first few hours of symptom onset. The current AHA and American College of Cardiology recommendation is to check troponin level on presentation and then 3 to 6 hours after symptom onset, and repeat 6 hours later if the patient has intermediate and high risk clinical feature or any ECG changes. However, more sensitive assays show better diagnostic performance for patient presenting soon after symptom onset and allow for early repeat testing. Specifically, high sensitivity troponin value below 99 percentile at presentation and 1 hour later have negative predictive value of more than 99.5%. Moreover, the values below the limit of detection at presentation have negative predictive value of more than 99.5%. Therefore, the European Society of Cardiology guideline now recommended at 0 to 1 hour or 0 to 2 hour approach when high sensitivity troponin is available, examining both absolute values and change over time. Regarding cardiac imaging continues to assume increasing importance for early diagnosis of patients presenting with suspected Nstemi ACs, especially when ECG is normal, non-specific, and obscured by LVB and pace rhythm. So myocardial perfusion imaging with technetium Nstemi B has been useful for patients presenting with chest pain in emergency department without diagnostic ECG or positive biomarker to discriminate patients with coronary artery disease from those with non-cardiac chest pain. Similarly, echocardiography is useful to screen for regional and the global LV dysfunction, which may help in establishing the diagnosis of ischemic heart disease for patients who present to the emergency department with chest. Coronary computed tomography angiogram has also been shown to be effective for excluding coronary artery disease among patients presenting to emergency department with low risk chest pain, non-diagnostic ECG, and negative biomarkers. So all these modalities can also assess LV function, powerful determinant of subsequent prognosis after MI. Coronary angiography is also used to establish diagnosis of disease and is considered the gold standard modality to define the extent of coronary disease and as preclude to percutaneous revascularization. Now, regarding risk stratification, the process of risk stratification for patients with Nstemi ACS refers to two simultaneous processes. It is frequently carried out at the time of hospital presentation like risk assessment, that is prediction of mortality, morbidity risk, and selection of the treatment strategy, that is early invasive and early conservative approach. So risk assessment using clinical ECG lab imaging data identifies which patient they are at the highest risk for adverse outcome. Moreover, the data from several trials have demonstrated that early risk assessment has also been useful for predicting which patient will derive greatest benefit from the most potent antithrombotic therapies, such as low molecular weight heparin and glycoprotein 2B3A inhibitors. So the risk assessment can be similarly be used to determine most appropriate level of care and monitoring. The management strategy refers to whether early angiography is performed directly following index event or whether conservative or ischemia-driven strategy is carried out. First, with non-invasive assessment of residual ischemia, followed by angiography and revascularization, only if recurrent ischemia is demonstrated. Now, risk assessment using clinical predict. The initial clinical evaluation can be used to risk stratify patient quickly and to assist with triage and early management strategy. In addition to age, gender, and significant comorbidities, certain aspects of the clinical presentation can yield valuable information. So, high risk patient can be identified by the presence of pain at rest, increasing frequency of symptoms leading to the index event. Furthermore, tachycardia, hypotension, signs of heart failure portend a poor prognosis. In particular, Kilip classification of heart failure severity has been shown to predict both short and long-term mortality for patients with Nstemi ACs. Now, the risk assessment by the electro ECG. The admission ECG can be quite useful for predicting early and long-term adverse effects. In the global use of strategy to open occluded coronary arteries to study, that is GUSTO to study, the presence of ST segment depression of more than 0.5 mm was associated with highest risk of 30-day and 6-month death and reinfarction compared with the T-wave changes. In the TIMI 3 registry of patients with Nstemi ACS, multivariant predictor of 1 year death and the M or MI included left bundle branch block in ST segment deviation of 0.5 mm or greater. In contrast, the presence of isolated T wave changes was not associated with significantly increased risk of death or MI compared to no ECG changes. The presence of ECG abnormalities has also been associated with greater treatment benefit from more aggressive therapies. The presence of ST segment deviation identified patient in both efficacy and safety of subcutaneous enoxaparin in non-Q wave coronary events and TIMI 11B trial who benefit the most from antithrombotic therapy with enoxaparin versus unfractionated weight heparin for Nstemi ACs. Similarly, in both fragment and fast revascularization during instability in coronary artery disease and treat angina with agrostat and determine cost of therapy with invasive or coronary strategy trial, that is TIMI trial, the invasive strategy had particular benefit for patients with HT segment depression at presentation. Thus, ST segment deviation is not only marker of increased risk of adverse outcome, but also identifies those patients who may derive greater benefit from aggressive antithrombotic and invasive therapy. Now, risk assessment by cardiac biopsy. Patients with Nstemi have a worse long-term prognosis than those with unstable angina. So, patients with elevated troponin, even with the normal CKMB, have significantly worse prognosis. Beyond the binary positive or negative result, there is linear relationship between the level of cardiac troponin T and I in the blood and the subsequent risk of the death. The higher the troponin, higher the mortality risk. Thus, cardiac troponin is useful not only for diagnosing infarction, but also for assessing risk among patients who presents with the NSTEMI. Given the enhanced sensitivity and specificity, cardiac troponin is preferred marker of myocardial necrosis for both diagnosis and prognosis. So, the presence of elevated cardiac troponin level also correlates with the utility of particular therapies. In a trial examining the benefit of apixaban among patients with NSTEM, the reduction of death or MI at 6 months was 70% for those who were cardiac troponin T positive, whereas there was no significant benefit for those who were troponin T negative. In TIMI trial, even when looking at patients who were CKMB negative, those who were cardiac troponin positive derived significantly greater benefit from enoxaparin versus unfractionated with heparin compared with those who had both marker negative. So the research has demonstrated that cardiac troponin level are useful when choosing invasive and conservative strategy for patient with NSTEMI. In both the Frisk and Tactis TIMI trial, patients who had positive cardiac troponin T and I had a dramatic reduction in cardiac event after allocation to invasive strategy. So, there is evidence from the multiple trial that the use of troponin can assist in both assessing the risk and determining which patient will derive most benefit from the potent antithrombotic agent and invasive management strategy. High sensitivity CRP and BMP also carry independent prognostic value in NSTEMI ACH, the latter of which has the marker of LV strain and heart failure. Now, risk assessment by the imaging. Echocardiography is widely available tool to assess LV function at bedside. The presence of new wall motion abnormality is one of the diagnostic criteria for NSTEMI and therefore has important implication for downstream risk. Coronary CT angiography is increasingly used tool for patients with the low risk chest pain, including low moderate risk unstable angina for risk stratification. A negative CT angiography carries very high negative predictive value and helps avoid unnecessarily invasive testing. Now, the combined risk assessment score. The current AHI, ACC, and ESC guideline for management of NSTEMI ACS recommends the use of risk score to facilitate decision regarding triage and management strategy. Now, the TIMI risk score for unstable angina and NSTEMI uses readily available clinical factors, ECG changes, cardiac biomarkers. It consists of following 7 risk factors like age, 65 years or older, more than 3 risk factors for coronary artery disease, documented coronary artery disease at catheterization, ST segment deviation of 0.5 mm or greater, more than 2 episodes of angina in past 24 hours, aspirin use within the prior week, and elevated serum diabetes. Use of this scoring system was able to risk stratify patients across 10-fold gradient of risk from 4.7% to 14.9%. The GRACE risk score incorporate multiple characters on admission to identify patient at risk of in-hospital and 6-month mortality following ACS. This model include age, heart rate, systolic blood pressure, serum creatinine, presence and severity of heart failure according to Kilip class, whether or not there was a cardiac arrest at admission, ST segment deviation, and elevated cardiac marker at presentation. When applied to patient with Nstemi ACS, the GRACE risk score is also able to identify those patients most likely to benefit from early invasive strategy. The timing of intervention in patient with acute coronary stroke trial in the Nstemi ACS patient with a GRACE score of greater than 140 had 35% reduction in primary endpoint with early coronary angiography when compared to the delayed intervention. In patient with the GRACE score of less than 140, there was no difference between the groups. Therefore, combined risk assessment score can not only identify those patients at high risk for adverse cardiovascular event, but also assist the clinician with management decision regarding antithrombotic therapy and coronary angiography. Thank you, guys.